Hi, everyone. Our patient today is a 65-year-old male with no known comorbidities. He presented with a history of central chest pain radiating to the left arm with numbness in the fingers. Patient reported that the pain was severe 3 days before presentation. Currently the pain is described as dull but constant. It feels better after intake of aspirin. It is worsened on exertion. Now let's analyze the ECG that was done on the patient. His vitals were stable. See if you can guess the answer before the analysis is completed.
Hi everyone. So I'm guessing you're all wondering what's happening in the last slide. Just trying out something new, and hopefully you all will enjoy it a bit more. Been told that my voice is better suited to newspapers, and my face definitely does not belong on any sort of screen. So as our young doctor on the previous slide was telling us, we've got this elderly man presented with pain that had since disappeared. And this is a real case that was sent to me by Dr. Suji, so thanks to him as well. And in this, we just want to cover how we would analyze this ECG. So we have this patient where all of the pain has subsided. He's only getting pain on exertion. You may start to think that it's an unstable angina or something along those lines. So I'm going to try my best to show you guys exactly what's going on. And if you have a chance, maybe pause this, go through the ECG that we've got here, and maybe try and decide for yourself what could be going on. So what we have, if we look here, it's just going to start, we're going to look first um, at the axis. So if we look at lead 1 and lead AVF, we can see that we've got a positive and a positive axis. So this actually tells us that we've got a normal axis, which is fine. And if we look at the rhythm strip, which is AVF in this case, sorry, lead 2 in this case, sorry, that was AVF over there, sorry, just got a bit mixed up. His machine had actually recorded it, a bit slanted, so that's probably why we've got it the way that we have. So we can see that we've got a normal P wave over there. Our PR interval was normal as well, and our QRSs were quite narrow, and we had a QRS following every P, and the bunches of P QRS were relatively regular. So we've actually got a patient who's got a sinus rhythm. There's nothing much from the rhythm point of view, and if we look at the rate as well, we've got a rate that's well within normal. It's about 70 somewhat. So we're looking at a patient who could possibly have an ischemia as well. And I think that's the most important thing to decide here, because does this patient have an ischemia or not? So when we look at the ECG, remember, if any of this is confusing you, please go back, look at ECG Basics, the entire playlist that's there, and that will assist you quite a bit. So if you look at leads 2, 3, and AVF, which we have over here, we just have a slight ST elevation, but very slight ST elevation in lead 2 that we can see over there. You can see it sometimes on the rhythm strip as well, but because of the curved nature, which is something that you'll face as a doctor, which is something that you'll face as depending on the type of machine that you use in that. So it's not something that you shouldn't be used to. But then you've got to say, okay, if I'm going to say that this is an inferior infarct, I've got to be able to check for reciprocal changes as well. Yeah, so like I was saying, if we need to have a look and see if there are reciprocal changes anyway. And I'm sorry, the two pictures are back to front. This is your limb leads, and these are your precordials. They're normally the other way around. So the one thing that you'll notice as you go through is that you don't really see reciprocal changes in this ECG at all. So if we come back and we have a look at the rest of the limb leads, if we look at AVR, we notice that there's not much wrong over there. And if we look at leads 1 and AVL, which are your high lateral leads, we actually see a bit of an ST elevation there, but very mild. Now, the main thing that I wanted to draw your attention to is actually what we see here in V1, V2, V3, and it extends all the way up to V4 and V5, is this biphasic T wave that we can see here. Now, we had actually discussed this just before we went on break, and for those of you who had paid attention, I think about 40 people watched the video from what I had seen on YouTube. You should be able to pick this out immediately and know immediately what's going on. So the biphasic T wave, especially in V2 and V3, is quite indicative of Wellens sign. And it's one of the two forms of Wellens sign, the other one being a deep inverted T wave that you get as well. So this biphasic T wave tells us that there is ischemia, and not that there's just ischemia, but that there's ischemia of the left anterior descending artery, which is now probably your main artery. And very often what happens is that your patients experience denervation of the nerves that are running along with the, that are branches from the vagus. So the patients often experience what we heard in the history, which is severe pain, which then resolves on its own or becomes dull and constant, and is often resolved, without the patient having to do much. And the patient then presents after a few days, not feeling well. Sometimes they become quite unstable as well, depending on the extent of the infarct. Now, in this case, the infarct was quite extensive. And just to give you a further history on this patient was then transferred down to a private clinic in Pietermaritzburg, where they did an angiogram. The angiogram showed quite a significant blockage of the LAD, and his troponins and his his troponins were 200 from what Dr. Suchi had told me. I think his isomer CK was also increased quite dramatically, and the patient was then stented and has made a good recovery. So it's applauded to Dr. Suji as well that he actually did, a good job in managing this patient and making sure that everything was done correctly. So I hope this will help you guys. What we're going to do now is that we're going to go on to another slide where again another one of our doctors is going to explain to us exactly what you need to know for Wellens and how you should go through it. And I hope you guys will enjoy it. And it means that you don't just have to listen to me and my dull voice and look at my dull face. So I hope you guys will enjoy that as well. And I hope you guys will remember Wellens from now on. And just shows you that it does occur in real life. It's not something that just occurs in the textbooks. Okay, let's listen to everything about Wellens.
Flowchart for Wellens sign on an ECG. Starting point, clinical presentation. Description, the patient presents with a history of chest pain, typically resolved at the time of ECG. Identification of Wellens sign. ECG shows characteristic patterns in precordial leads, V2, V3. Deeply inverted or biphasic T waves. No or minimal elevation in ST segment. Implication of coronary artery disease. Wellens sign indicates critical stenosis of the left anterior descending, LAD, coronary artery. Avoidance of stress tests. Stress testing is contraindicated as it can provoke myocardial infarction. Immediate management. Cardiology consultation. Preparation for potential coronary angiography. Monitoring for acute myocardial infarction. Endpoint, intervention and long-term management. Possible coronary revascularization, angioplasty or bypass surgery. Long-term cardiac management and lifestyle modification.
Thank you so much if you've stayed right till the end, and we hope you enjoy it. And tomorrow we'll have another one. Keep well. Bye.